Hi everyone, good evening and welcome to our webinar tonight. I'd like to start with welcoming our audience, and of course we will have a lovely evening today with our well-distinguished guest speaker. She is Professor Wilmshurst, and she is really gonna give us a good talk. But let me first present her to all of you. She is the head of the Pediatric Neurology Service for Red Cross War Memorial Children's Hospital, which is the leading hospital affiliated to the University of Cape Town in South Africa. It is the largest children's hospital in the sub-Saharan Africa, which cares for children from across the region. She is involved in clinical service provision for children with neurological complication inclusive of dictated neuromuscular services as well as complex epilepsy services, and have been involved in research studies in these areas. She is really having more than 100 of publications involved in so many activities, scientific and research work, and she's having a really long list of excellent activities and responsibilities. And I'd like just to now introduce her, and she's going to give us a talk about neonatal seizures, and I hope you will get all the benefits of her knowledge, experience, and the floor is yours, Professor.
Thank you so much, Dr. Tawari. And just to welcome the panel that we've got with us today, inclusive of Dr. Tawari, Dr. Al-Baradei, and also Dr. Presler. So the talk that I'm going to give today, as Dr. Tawari said, is titled Neonatal Seizures, and it's going to be divided into three main components, focusing on what we know about the classification, the treatment, and really how we can relate and consider this in resource-poor settings. So just to start, these are my disclosures. There are some videos in this presentation. Please don't copy them. And also just to acknowledge that some of the slides Dr. Ronit Presler has very kindly shared with me. So when we think about the reality of managing neonates, it's really key that maternal health is critical for a healthy baby. And for neonatal deaths globally, there are three major causes: infections, prematurity, and birth asphyxia. And when we look at the incidence of neonatal deaths, there's huge disparity between resource-equipped and resource-limited settings. Of the survivors, not surprising, neonatal seizures are a major complication. So diagnosing neonatal seizures in infants can be incredibly challenging. They can have non-seizure behavior that can look identical, be mimickers, and a significant proportion of neonates have electrographic seizures, subclinical seizures. These are exacerbated in the setting of a critically ill infant, those on muscle relaxants, in the setting of having uncoupling or electroclinical dissociation, and further compounded when anti-seizure medications are given, with the result that in an ideal world, we really should be doing EEG monitoring in all of our neonatal units. So the diagnostic challenges that face us are compounded if we look at the setting of one of the commonest causes for neonatal seizures, hypoxic ischemic encephalopathy. 50 to 80% of the seizures will be electrographic only, with the result that the extent of the seizure burden, namely the time spent with seizures, defined as the electrographic seizures in minutes per hour, may be greatly underestimated. So the electroclinical dissociation may be further exacerbated in the setting of giving therapeutic hypothermia, which, as we know, is gold standard intervention in the setting of an infant with hypoxic ischemic encephalopathy. The electrographic seizure burden is reported to have comparable effect on outcome as the clinical seizures themselves. So uncoupling that men may be further increased with the administration of anti-seizure medications, especially Phenobarbital. So we're left with this dilemma of trying to accurately diagnose neonatal seizures, and there are many challenges in doing this. So this is a breakdown graph that is included in the recently published classification of seizures, of neonatal seizures. So you have a setting here where you may have a baby who's at high risk of seizures, with or without the clinical events. And in an ideal world, you want to have an EEG. So let's just go down the track where we're lucky and we do have access to those resources. So you have an EEG available, and in fact, it's the full continuous EEG. And this correlates with picking up electrical activity. You then have a level 1 gold standard confirmation of a diagnosis of seizures. And that's your ideal setting. That's what we would all like to have. Further, you may have a situation where you do the recording, the movements occur, or there are no movements, but in fact, the background does not reveal any evidence of seizures. And you can be sure, you can categorize this as a level 5 and no seizures in this neonate. Similarly, you may not have the resources to have the continuous EEG, but actually have the amplitude integrated EEG. So the specificity of this is not as strong, but it still has a role and is useful. And in this setting, the recommendation is that if you perform this screening and you detect abnormalities consistent with electrical activity, then you can make a level 2A diagnosis of probable seizures, allowing you to decide about intervention. However, if you don't pick up anything, then you have to go to a level 4 where there's insufficient evidence and revert over to the observed experience, what the clinical observer is seeing. If they see movements that they suspect are seizures, and those movements appear to be focal clonic or focal tonic, we know that in neonates in this setting, it's highly likely to, in fact, be seizures, and you can have a level 2B probable diagnosis of seizures and intervene based on this. But for any other movements, any other seizure types, it's only a possible diagnosis. And likewise, if you have an observer who thinks that they're not seeing seizures, again, without the EEG correlate, you cannot be sure. So this is the adapted diagram that was used in the Brighton collaboration and has been implemented in the classification, which we're going to talk more about now. So let's now revert back to a setting where we don't have access to EEG. You're going to have a neonate with a clinical suspicion of seizures, but you may be in a setting where you've got either no EEG or inadequate monitoring available, and you'll end up with 3 scenarios. You can't be certain that it's a seizure. If you're lucky, they're focal, and then you can be sure, more sure, or you can't make a diagnosis at all. And so the clinical setting where this occurs is if you have the motor, clonic, or tonic movements, then they're probably focal seizures, and you can be sure that you need to be intervening. Whereas if there are any of the other movements, you actually cannot be certain without having accurate EEG correlation. And if you don't have EEG at all, and you've just got the electrographic seizures, then actually you're going to miss it and you're not going to be diagnosing it. So I think this really does emphasize what a barrier it is to care if you don't have access to EEG. I think I probably hopefully emphasize that there is a really strong need to have an accurate classification of neonatal seizures. The International League Against Epilepsy has formed seizure classifications, but they don't include neonates. So the task force were encouraged to do this. The neonatal task force led by Ronit Presler initiated this, and they worked for many years, as you can see, with the aim to adapt the newest seizure classification specifically for neonates with the same principles and terminology as the classification for older children, but with also emphasis on the need for EEG. And this is now published. So if you can't keep up with everything we're talking about today, the paper is available and beautifully written and very clearly laid out. But these are some of the key points that have come through from it. So this is from the original classification by Bob Fisher for all seizure types in older children. And straight away, it was possible to exclude a number of these items. So neonates do not have enough brain myelination to generate generalized seizures. So likewise, this goes out. And you cannot accurately ascertain their level of awareness. So these factors go out. So in fact, the areas that we should be focusing on become simplified significantly in our clinical approach to neonates with seizures. So when you're faced with a critically ill or a clinical suspicion of seizures in an infant, your differentiation should be as follows. That you ideally have video EEG or amplitude integrated EEG at the very least. And with the aid of this, when you assess the infant, you find that there are non-seizure episodes that are supported with EEG correlate, or you may have seizures that do indeed have your EEG supporting evidence. And then you want to differentiate into what types of seizures are you seeing. So if there are clinical signs, then the drop-down list that you will be looking at will be these motor phenomenon, non-motor phenomenon, and sequential and classified that I'm going to unpack for you a bit more just now. If you don't have clinical signs, then you indeed have your electrographic seizures. So it's important to remember in this world where we are dominated for the neonates that we treat with neonatal seizures with HIE, that in fact there are other causes. And of the early onset epilepsy syndromes, 10 to 15% of them present in the neonatal period, related to genetic, metabolic, and cortical malformations. The EEG background can be useful, and there may be specific features that would aid closed diagnosis or targeted approaches. They have a high comorbidity rate, so they're important to recognize, and it's occasionally targeted therapies indicated. So this is, again, further work performed by Ronit and her team, where they looked at a cohort of babies from a number of centers who presented with neonatal seizures. And they used their careful delineation of the underlying etiologies, as listed here by the pie diagram, to map this against the typical seizures that were seen. So you can see that for hypoxic ischemic encephalopathy, the predominant seizure type illustrated here was electrographic. For vascular seizures, the predominant seizure type was clonic. For infectious, again, electrographic. For metabolic, high levels of myoclonic seizures. For genetic, again, getting tonic seizures coming through, as well as sequential. And for the premies, getting high numbers of electrographic seizures, as well as myoclonic and clonic seizures. So this is incredibly useful to take their understandings and to map it against both the classification, to challenge that, and to see how it can really help you in your understanding of your neonates. So let's roll on to treatment and what do we do? So in 2011, we completed the work with the WHO and the International League Against Epilepsy for the guidelines for neonatal seizures. And this was an interesting work, and it highlighted a number of quite useful outputs, such as which seizure events to treat. And there was strong recommendation that came through for treating seizures that are 3 minutes or longer, or brief serial seizures, that clearly one should perform any basic screens that you can that will have a huge implication on management, such as addressing hypoglycemia, treating sepsis and other infections, and thinking about electrolyte imbalance that can be correctable. And what seizures to treat? Well, phenobarbital remained the first-line recommended agent, but a very clear message that if you have an infant that presents that you think might be at risk of neonatal seizures, but you have no evidence that it has occurred, prophylactic phenobarbital should not be given. What interventions and investigations? So EEG was strongly supported that it should be performed to confirm all clinical seizures and to identify electrographic seizures, but it should not be used to identify etiology. Neuroimaging should not be performed to identify seizures, but it can have a role for supporting etiology. So The messages that came through is that there were a few useful recommendations, but it was quite clear that there were challenges to these recommendations, that they needed to be used with caution, they had to be adapted at the local level according to the resources available, and that they were in great need of being evolved with time. What they did do was they highlighted the lack of consistencies in practice and the need for further research into areas of common day-to-day practice. And really critical, one of the biggest challenges with trying to combine the studies that did exist was the lack of consistency in the use of classification of seizures, which is really why the publication I've just reported to you on classification of seizures is so very, very important to allow consistency and comparison across studies. So roll on the present day. So Ronit Presler and Hans Hartmann have been co-chairing a task force for the neonatal seizures task force for the League Against Epilepsy. And that term is finished, and they're just in the process of wrapping up the final outcomes, which they've given me permission to talk you through some of the key findings. First of all, I want to highlight to you how things have changed and moved with how, when we put forward these recommendations, we try and consolidate them and do them in as pragmatic and accurate a way as possible. So the International League Against Epilepsy has formulated a roadmap for how to develop clinical practice guidelines. And it starts at the beginning where you identify a gap specifically in epilepsy guidelines that need to be filled. It's approved by the League, and then clinical questions are developed. The working group is not just epileptologists, but is representative following the agreed principles of all people involved and invested in the area. The evidence is then explored. The evidence is explored extremely carefully and evaluated for the quality of the evidence to allow formulation of recommendations. Further to this, the role of peer review that the International League follows is that the guidelines are then put out for wide commentary throughout the League community, where all chapters and all members are allowed to have a view, a comment, and input into the findings that then the group go back and assimilate and review. The League also has a publications committee that also vets and views it and performs its own independent review, and then recommends a journal that would be suitable to allow the most prioritization of the recommendation, who then perform their own peer review. So this is then taken through as much and as stringent a process as possible to allow then the appropriate dissemination and implementation, with a plan to then update it, because quite often they become out of date, usually within 3 to 5 years of publication. So it's a lot of work. So the priority questions were identified, and the first two were diagnostic questions, and aligned with these, the PICO structures were put in place, looking at population, intervention, comparator, and outcomes. But what the group rapidly realized was that we were going to outstrip ourselves and there wouldn't be time to get through this. So this was put on hold for the next term. So we're going to talk about treatments, and the following priority questions from 3 to 8 all targeted around treatment of neonatal seizures, asking what would be the best first-line treatment, second-line treatment, whether prophylactic medication should be continued after it had been started, the role of therapeutic hypothermia, whether or not reducing the electrographic seizures would make a difference on the neurodevelopmental outcome, and the role of pyridoxine. So literature searches were undertaken and updated, and the evidence was critiqued for the quality of the evidence to try and work out how strong the statements were that we could make. So starting with the first question, which is the preferred first-line anti-seizure medication in neonates requiring pharmacological treatment, specifically regarding the cessation of seizures, mortality, and adverse effects. So phenobarbital is the most widely used first-line anti-seizure medication in both term and premature infants. But in fact, the response rate in papers is anything from 6 to 90%. And there are very, very few randomized controlled trials with a huge variance in directness and consistency. So based on the few existing studies, the group concluded that phenobarbital is effective in treating neonates with seizures, but there was currently inadequate data to suggest levetiracetam, which is becoming increasingly promoted, that it was more effective than phenobarbital. This was then put forward to question in Adelphi for expert opinion. And in fact, the group supported Phenobarbital. Moving on to the second line intervention, which is the preferred second line anti-seizure medication in neonates, specifically regarding cessation of seizures, mortality, and adverse effects. There were a number of papers identified, but not many. So the one by Painter, looking at phenobarbital versus phenytoin, this identified similar control and adverse events. The paper by Sharp, looking at levetiracetam versus phenobarbital, there was better seizure control with phenobarbital, but more adverse events. And then the paper by Geraldine Boylan, looking at Lignocaine versus midazolam. Worryingly, there were no responders in the midazolam group, but the numbers were very, very small. So there were inconclusive results and marked variance in the studies. Adelphi was again performed, and this didn't result in any consistent consent or agreement across the respondents. So phenytoin came up as the most preferred agent, but not enough to make it the recommended agent, followed by levetiracetam. Following cessation of acute seizures, will continuation of prophylactic anti-seizure medication improve neurodevelopmental outcome and the reduction of subsequent epilepsy, specifically which neonates to continue treatment and the length of the treatment. So at the time of when we were performing this study to evaluate the role of prophylactic anti-seizure medication, there were no prospective studies that explored neurodevelopmental outcome as a primary endpoint and looking at a reduction of later epilepsy in neonatal seizures. So we proposed a Adelphi question. Following cessation of acute provoked seizures, electroclinical or electrographic, without indication for neonatal onset of epilepsy, so these were acute provoked seizures, pharmacotherapy should be discontinued before discharge home. And there was strong consent to agree that you should stop anti-seizure medication in a well infant who had provoked controlled seizures before discharge. What was reassuring is that following this, Hannah Glass and her colleagues published the study that really addressed most of these issues. So this was a huge study across 9 centres. And what they found was that in the group that where they stopped the anti-seizure medication before discharge, there was no difference in the outcome for the neurodevelopment or subsequent developing epilepsy in those infants. So they said the results strongly supported discontinuation of anti-seizure medication prior to hospital discharge for most infants with acute symptomatic neonatal seizures. The next question is, in neonates with hypoxic ischemic encephalopathy, does therapeutic hypothermia reduce seizure burden? So there were a few papers that address this, and I'm going to unpack some of these a bit more in the next section. There was moderate certainty that seizure burden was higher in the non-therapeutic hypothermia groups, and that the mean seizure frequency was lower in those managed with therapeutic hypothermia, so supporting the intervention. It was quite challenging because as part of gold standard care, most units will now undertake therapeutic hypothermia for neonates in setting having HIE. So accessing a randomized control study was going to be quite challenging, and we knew that. Question 7 was, is a reduction of the electroclinical and or electrographic seizure burden associated with improved neurodevelopmental outcome and reduction of subsequent epilepsy? So the literature has supported an association between neonatal seizures, seizure burden, and outcome. But in fact, there were no studies that addressed whether decreasing seizure burden is associated with improved neurodevelopment or the risk of epilepsy. And most studies were not relevant to the topic, or in fact lacked data on continuous EEG confirmed seizures. So the group put forward a Adelphi question of, irrespective of etiology and degree of brain injury, reduction of electroclinical and or electrographic seizure burden is associated with improved outcome. And there was a very strong consensus that this was indeed the case. I feel like I have to just highlight to you a recent publication which has come out arguing this point. So this is a randomized controlled study, and this compared 2 groups a group with blinded interventions. Although the infants were being monitored, the clinicians did not see what the EEGs were showing, but these were amplitude integrated EEGs. And what they found was, in fact, that there was little difference in the mortality or neurodevelopmental outcome. And they argued the point that it made no difference whether you were monitoring the infants or not. Now, I had to say to you, this is devastating for us in resource-limited settings to have publications such as this come out, because it removes our lobbying capacity for what I think we all agree is an essential resource in managing neonates carefully. So there are a number of letters being written to try and balance the findings in this report and be a voice of reason. Some of the confounders that I will just say to you now is that this was multi-center, there was potential observer bias, the monitoring was not continuous EEG, and the enrollment was well after 6 hours, so could easily have missed hectic seizures that could have been ongoing in the prior time before the study actually commenced. So within the neonatal world, there's great caution in this study outcome. And then in neonates with seizures, is the use of pyridoxine or pyridoxal phosphate effective and safe? So whilst it's entirely logical to offer pyridoxine or pyridoxal phosphate in therapy-resistant neonatal seizures while awaiting diagnostic information, the response was variable since the outcomes were based on small numbers and variable therapeutic approaches. Neurodevelopmental outcomes also were affected by specific factors rather than solely being dependent on how soon the pyridoxine was given after seizure onset. So again, it was difficult to form closure for this. So let's pull these questions 3 to 8 together and just consolidate what was the key findings. So for question 3 of a first-line intervention, the group agreed that it remained phenobarbital. Question 2, it undecided, so either phenytoin or levetiracetam. Question 5 about discontinuation in acute provoked seizures before the time of discharge. Yes, you should. The role of therapeutic hypothermia in HIE to reduce seizure burden, there's moderate certainty that you are indeed doing this with the intervention. Does the electroclinical seizure control improve the neurodevelopmental and epilepsy outcome? Well, the consensus from the group is yes, far against the views of that one paper. And then pyridoxine is logical to use, but we need more outcome studies. So this is really where we're at with the recommendations for treatment. So now we need to think about what are the implications for where many of us work in really less resourced equipped settings and the barriers that we face for implementing these wonderful care plans that are being proposed to us. So the reality is that there's marked disparity in the ability to deliver care between a high income and a low income setting. There are poor obstetric facilities, lots of home deliveries, and often poorly equipped neonatal units lacking ventilation support, capacity to deliver head cooling, even a sustainable supply of antibiotics and anti-seizure medications, and limited monitoring of the neonates being possible. And overall, often failure in structure and organization of how the babies are recognized and even get to the neonatal unit. So management in resource-limited settings. In an ideal world, you must exclude the most commonly reversible causes using what you have available to you. So manage the fluid status, correct the glucose, explore the electrolytes, manage infection. For many of the units that I've been involved with work and project across parts of Africa, they can often do little beyond checking the dextrosticks, and access to timeliness and accurate results from electrolytes and infection screens are often lacking. So the assessment has to be a clinical and presumptive one. For using anti-seizure medication, most protocols will include phenobarbital and various benzodiazepines, with levetiracetam and lidocaine slipping into some, but often not available. So there's a lack of access to levetiracetam. The cost is often preemptive for the centers we work in, and a great caution about the use of benzodiazepines with worry about airway suppression and not being able to provide airway support. And a lack of consistency, in fact, in even following the WHO guidelines from 2011, with some centers still giving prophylactic phenobarbital loading with an infant that lands in the unit presenting with HIE. So just really to focus on that question of what can we do and are there things that we can do? So therapeutic hypothermia is a critical intervention in the setting of HIE. It is accepted as the gold standard of care. So current studies coming out now mean that they don't have comparison groups, because if you're doing studies ethically and you're implementing therapeutic hypothermia, how can you possibly have a group that doesn't have it? So it's challenging to develop other models to compare the efficacy. And that overall studies, however, do support that therapeutic hypothermia reduces seizures burden in neonates with HIE and seizures. But this is mostly based on the group with moderate HIE, and that medical interventions such as using phenobarbital may well promote your positive outcome. So we have seen a rollout of innovative and low-cost cooling options. And these are targeting early intervention models to reduce the immediate and long-term impact of neonates with HIE and related seizures. But the problem is analyzing the outcome of these has been limited by poorly powered clinical trials. There have been various innovative methods that have been explored, but there are residual safety concerns, challenges that the therapeutic benefit may be difficult to translate into widespread clinical use. So there's been this wonderful study, the HELIX study, across India, Sri Lanka, and Bangladesh, which did manage to do a randomized control study. Unfortunately, it didn't explore the seizure burden. So I think we had great hopes that this was going to answer some of the questions, but in fact, that wasn't the focus of this study. So looking at this meta-analysis, this explored studies from Africa, India, China, Turkey, and Malaysia, and they identified all of these diverse tools for using cooling. And what they concluded from the end of it was that you needed more randomized controlled trials, and also that you actually needed to have better observation from nursing and support from the staffing infrastructure. So when they then pooled this data, they actually found that therapeutic hypothermia was not associated with statistically significant reduction in neonatal mortality in the low and middle income country setting. But this was compounded by the heterogeneity and poor quality of the studies, the lack of efficacy of the cooling devices, and the limited neonatal intensive care capacity, plus the intrinsic differences in the populations that they were managing, where there were higher rates of perinatal infection, obstructed labor, and maternal malnutrition, and intrauterine growth retardation, with the result that they promoted the need for adequately powered randomized controlled trials to establish safe and effective cooling devices that could be rolled out and used in low and middle income countries. This is further compounded when we look at access to therapies. So I've repeatedly said that phenobarbital should be the agent that we should be using. And when we look at this study from central and southern Malawi, when they screened various units, even in the private clinics, only 50% of them had access to phenobarbital. And in the public facilities, it dropped down to 25%. So there have been some recommendations put forward that can be adapted within the lower middle income country setting. So this paper is still useful and is still relevant, and in fact works quite well when mapped with the recommendations that will come out and the classification. So I'm not going to go through this diagram, it's far too detailed, but it's available in this open access paper, and it takes you through an initial management for abnormal movements in a clinical setting that accepts that you are unlikely to have EEG or even basic laboratory studies available to you. It then leads you on to where you may have more advanced diagnostic studies, where you can do more, and what you should probably be trying to achieve in your unit. And it takes you through a medical management plan of interventions that you should consider implementing. And this is a very logical approach, and it's quite a nice, useful starting point in units that have had very limited resources. So also, when we do these guidelines, it's important to see how they could be adapted and translated into actual clinical practice. So this is a tool that was developed from Asia, and it's a very nice, useful, user-friendly approach. And what this group did was they developed a series of modules specifically for sick neonates. And as you can see here, there's this subsection specific to neonatal seizures. And This is a great way of adapting and making available to people who may not have full training a resource to help and support them. So what recommendations can we take through for resource poor countries? You need to treat the treatable. So correct the glucose, fluid and infections as much as you can. When you don't have EEG, you need to follow the guidelines established by the Global Campaign Against Epilepsy, an initiative that was driven by the League and the WHO. So these are the 2011 guidelines, as well as the mental health guidelines. Clonic seizures, if you can see them, are more reliable to be certain that they are seizures, as well as focal tonic seizures and some sequential seizures. So these you would have a good case for treating. Whereas automatisms, autonomic seizures, and seizures with behavioral arrest, you would really need an EEG to be sure. And electrographic seizures, by definition, are going to be missed if you don't have an EEG. So you need to be lobbying for access to better EEG tools, as well as the ability to interpret them. And you need to be lobbying for adequate pathways for optimal care of neonates with seizures. Thank you. I would really just like to acknowledge the group who are from all over the world, and I've so enjoyed working with them, and I've learned so much about neonatal seizures, and especially from Ronit, who we're lucky enough to have here on the panel tonight, and Hans, the other co-chair. So I'm going to stop sharing here so you can see all of us, and hand over to my panel colleagues.
Yes, thank you so much. Really, that was interesting, quite comprehensive, quite attractive, and really I enjoy it. Now we will open the floor for discussion. There are questions from Dr. Joyce. When do you stop phenobarbital once started?
I can answer that, but Ronit, do you want to take it?
I believe it was heard from the talk, but it was, I mean...
But I think we should reinforce it because it's a really important point. And I think, Ronit, do you want to maybe...
Sure. It is a very valid question, really.
It's a really important question.
I agree. It's a very important question. So if, I think, in principle, if a baby responds to treatment and is seizure-free, then medication should be discontinued before the baby is discharged from the hospital if there is no indication that this baby has an early onset epilepsy. So if it's acute provoked seizures due to HIE or stroke or an infection or anything, or hypoglycemia, then medication should be stopped before the baby is discharged. Obviously, this is different if this is early onset epilepsy or if the baby did not respond to medication, is not seizure-free. I think, in a nutshell.
Maybe Dr. Raida will have more inputs. Dr. Raida?
Yeah, thank you very much. As you mentioned, it's a very important question, and I totally agree with what's mentioned from the talk and Dr. Ronit.
And I think it's reassuring that that big study that Hannah Glass did came out, but it's interesting that the task force had already come to that conclusion and was very clear, because there's never a free ride. All these medicines have side effects, so the shorter the duration you can have a baby on medication, the better.
The other thing, absolutely, the other thing which might be important to add is that in the past people used to say, oh, we stop medication if the EEG is normal and the MRI is normal. But actually, it doesn't matter if the EEG shows focal abnormalities or background abnormality, or if the MRI is abnormal, because of course it will be abnormal if this baby had HIE or stroke. So the decision to stop medication should not depend on any background abnormality on the EEG, if you have EEG, or any abnormalities on the MRI. Only if there is a suspicion that the baby has epilepsy, nothing else.
Mm-hmm. Excellent. There is more questions. Any role of clobazam in neonatal seizures? Maybe Ronit will answer.
I'm happy to. I mean, it's difficult to say because there are no studies. There are really no bigger studies to show whether it has a role. I think we know for other benzodiazepines, most studies have been done in midazolam, and it is effective, but it's usually used as second and third line medication. But basically, we don't know. I don't know, Joe, what do you think?
Yeah, exactly. We don't know. And I think there's quite a lot of anxiety because of the potential airway suppression. I think also giving clobazam, I don't know what formulations you have, but I mean, when we've used benzos, it has either been midazolam or clonazepam, but we don't have a lot of success with either of them.
Yeah, I would like also to put my inputs here. In our practice, clobazam is not have a role in neonatal seizures, but maybe in other centers they may have their own experience. In my place, we don't use clobazam in neonatal seizures. As you have mentioned, phenobarbital is first line, and the second comes the levetiracetam. So this is good. I mean, they said brainstorming question. It is effective in other form. I mean, later onset epilepsy, clobazam, we have good experience with, but in neonatal seizures, in our practice, we cannot put it as a choice for treatment. We don't know what would be. This is our practice. Maybe you have similar. Okay.
That's right.
The next question. Yeah. The next question: in what case we recommend long-term anti-epileptic drugs in neonatal seizures?
I think whenever you have, if a baby does not respond to treatment or it doesn't become seizure-free, but only a reduction in seizure frequency, then of course you would continue medication. Or if you think that a baby has epilepsy. So for example, if you have a genetic epilepsy or a cortical malformation and the baby has seizures, then you would not stop because there's a high suspicion that this baby is going to continue having seizures and has epilepsy rather than early or provoked seizures due to an acute insult.
I mean, I think that's the critical thing, isn't it? It's making the decision that this baby actually has epilepsy.
Yeah. So acute provoked seizures is not epilepsy. I think the distinction is it acute provoked seizures or is it epilepsy? And if you have a baby with, for example, stroke, most babies with stroke will stop having seizures after 3-4 days. They may develop epilepsy years later, but the acute provoked seizures stop. But in rarely, these babies continue to have seizures straight away. And then if the seizures continue for 7, 10, 14 days and they don't stop, then the baby has epilepsy. That's a difference, I think.
Yeah, excellent. Thank you. There is a question, is there a simplified guideline paper for physicians?
I mean, hopefully when we write the treatment guidelines, when it comes together, I mean, looking at the layout that you're planning, Ronit, I mean, it depends what you mean by a simplified guideline. I mean, it's important that we know what the gold standard is, and then it's our job to be able to adapt that at the local level. But the way Ronit and Hans are putting it together is that they're putting it over in a very clear and methodical and logical way. So, I mean, when you say simplified, I mean, I'm not always sure what we mean by that. The Coe et al. Article, I included it in the talk, Ronit, because that would be the simplified guideline. But I would like us now that the two meet, and that gives you the chance of how would you then adapt your approaches. I don't know. What do you think?
Yes, I agree. I agree totally. I agree with you. I don't know our panelists have their opinion, maybe. Dr. Raida.
I think I totally agree. And what was conclusion from the first part, the second part of the talk, when what's the recommended first line of treatment is so far phenobarb is the most effective one to treat acute seizure in neonates, followed by levetiracetam. Phenytoin also has a role as a second line. And if they don't respond, you would go to other anti-epileptic drugs. So, and this is based on the evidence, which is and came later in the literature.
Okay. There is a question. Do you have evidence, suggestions for treating seizures in preterm babies? Currently, we have a 26 baby with a super refractory status epilepticus. So this is a question that really might be really practically for neonatologists or physicians or pediatricians having a super refractory status epilepticus that they need to treat in preterm babies. So I believe maybe Ronit would have an answer for this.
Yeah, I think in principle, the data we have doesn't suggest you should treat seizures in preterm babies any different to seizures in term babies. The only problem with is midazolam, which can cause myoclonic jerks in babies, so in preterm babies. So you have to be careful, but I have seen preterm babies respond to midazolam as well. So it's really difficult. The only thing I would say is what is in preterm babies particularly important is to monitor with EEG. So clinical seizures, clinically, it's very, very difficult because most of them have electrographic only seizures. And if they have movements, they are sometimes not seizures, even if they seem to be seizures. How old is the baby? How early?
26 weeker.
A 26 weeker.
It's hectic.
To be honest, I've never seen a preterm baby as 26 in refractory status unless it was something like pyridoxine-dependent seizures.
That's what I was going to ask you. Do you think that there's an etiology-driven compounder here?
Absolutely. I think this is something you have to, I mean, the first thing is really to look what the etiology is. Obviously, babies with inborn errors of metabolism can be premature as part of the inborn error of metabolism, and then they have seizures as well. But it's unusual for them to have status for such a long time.
Yeah, again, it is a quite challenging situation really for a neonatologist or a physician. This situation really, sometimes you need a full support to maintain the help for the patients or the babies.
Maybe sometimes you need to make sure that he is really in status. So, is it a seizure first to ask yourself, or it is something else? EEG might be helpful also in this situation before you give a lot of medication and you are not sure what you are dealing with.
That's a great point.
Yeah, I agree with Dr. Raida, but again, there is some centers in our world who have limited services. So sometimes integrated EEG or, continuous EEG wouldn't be possible. So really, these challenging situations, you would consider going up or upgrading your treatment from Phenobarbital to other and other. How would you support such situation? Would you go even to the steroid level for neonates? That's my question, just brainstorming one. No. Okay.
I think if you don't have proof that it's seizures, if you don't have EEG or AEG, I would not, because the chances that it's not, and actually there is no evidence that steroids are useful in neonates. There are no studies whatsoever. To be honest, yeah, most of the time, unless the baby's then an infant and it's 6 weeks old, then the whole situation changes. So if you have a baby who has seizures for weeks and weeks, and then the baby's 5 weeks old or 6 weeks old and has had seizures all the time, then you have an infant with epilepsy, and then you treat it as an infant, not as a neonate anymore. And you use you put your pediatric hat on and treat it as a pediatric. I think. Joe, what do you think?
Yeah, no, I completely agree. I completely agree.
But if you have a neonate who doesn't respond to treatment, and doesn't respond to first, second, and third line, actually, and the baby is like 4 or 5 days old, then I would step back and think again and think why does the baby have so severe seizures, and what is the prognosis, and what is the etiology, and maybe we have to stop chasing something we cannot win. It's a very difficult situation, but if you have seizures who don't respond to anything, I think it's important to step back and have a different look at this situation.
I agree.
Super, thank you. Okay, can you tell us about the use of benzodiazepine in neonatal seizures? Again, the benzodiazepine is hot in this session. Okay. Dr. Raida, maybe you'd like to have an input.
Yeah, sure. As it was delineated clearly, the first line, second line, and third line of treatment, phenobarb, phenytoin, levetiracetam. Sometimes if a seizure did not stop, you may use boluses of lorazepam, which is rarely used. It's not as common. I hate to use clonazepam in babies, as secretion can increase. So it is there is limited use of benzodiazepine in neonatal seizure, and also the studies is not as supportive.
Okay, thank you. Next question, what is the seizure burden magnitude in order to treat? Is it 5 minutes per hour or more or less? Yes, Ronnie.
Question, very important question.
Yeah.
To be honest, we don't know. The International Neonatal Consortium had a workshop on neonatal seizures about 4 or 5 years ago, and we published sort of recommendations. Janet Soul was the first author. And we looked at this, and there's really no data, but we recommend a seizure burden of more than 1 minute per hour should be the start for treatment is recommended. So 5 minutes is probably a bit more old-fashioned. Nowadays, we recommend to start treatment earlier.
Yeah, excellent. And I believe every second counts for the neonate. So you have, given the target answer. Thank you so much. Okay, the next question would be, if a neonate has more than 3 episodes of seizure, but all are less than 3 minutes, should anti-seizure medication be started? As we said, I think this is, confirming the answer that you have mentioned. Every second counts in the life of a neonate. So you have to interfere as soon as possible, control the seizures. Do you agree with me?
Absolutely. And I think the other thing which is really important is there is now evidence that the earlier you start treatment, the easier they are to treat. So the longer babies have seizures, the more difficult it becomes to control them.
Yeah.
So as you said, every second counts. Don't wait too long. If you wait for hours and hours, then you may never be able to control those, or not never, but it will take much more medication, and it may be much more difficult to control seizures than if you start early.
So I think the confusion here is because the WHO guidelines said that you intervene if the seizures are longer than 3 minutes. But actually what the doctors said here is that they were basically clustering. So it says more than 3 minutes or clustering. So if you've got more than one seizure, you basically got clustering, you have to intervene.
Yeah. Excellent. I mean, thank you for this illustration. Thank you. Okay, next question is amplitude EEG good alternative for continuous EEG in neonate? Maybe our speaker would like to have her input.
Yeah, I mean, EEG monitoring is needed, but continuous EEG is the gold standard. But most units in most parts of the world actually only have access to amplitude integrated EEG. So for clinical practice, that's often what they depend on. But in fact, for the quality of the studies that we need and evidence, we ideally want them to be using continuous EEG. And that would be really where we were heading towards. So yeah, amplitude integrated EEG is the first stepping stone towards appropriate management in neonatal units, but you ideally want continuous EEG.
Yeah, I would agree that it is a good alternative. The question is a good alternative. So I would agree for a good alternative for continuous. If you have this facility, some centers, as we have to know that they have limited services, so it's a good alternative. Yes, I agree. The next question, how long after the baby has stopped seizing can we stop the phenobarb? 24 hours to 48 hours. So maybe Dr. Raida would like to have an input here.
If the baby had seizure and start phenobarb, seizure stopped immediately, I would keep it for a few days just to make sure baby is not seizing and his examination is normal. EEG can be helpful also. If he's sure continue to be seizure free, definitely before discharging the baby home, we can stop the phenobarb.
Mm-hmm.
I will not put like 24 hour, 48 hours. It's too soon to stop the phenobarb. Just to make sure that what's going on is that, and it depends on the etiology. I mean, if they have to make sure that it is a seizure, it's not hypoglycemia, it's not hypocalcemia, it's not electrolyte disturbances, because it is treated differently. It is not with medication to start with. If it is if they found out that the etiology is symptomatic seizure due to electrolyte disturbances, there is no rule at all with phenobarb. Mm-hmm. But if the patient had, for example, symptomatic etiology, hypoxic ischemic encephalopathy, some sort of structural brain abnormalities, here you need to mild hypoxia, or here you need to investigate, do more investigation to find what's the etiology before stopping the medication prematurely. Yeah. We always encourage to stop the medication as soon as possible, but we'll be very careful when to stop it.
Yeah, I agree. We have to be, this is very practical, helpful point you have mentioned. The neonate health is important that the neonatologist or the pediatrician must have his own clinical basics to consider the stoppage of phenobarbital. What you have mentioned is really good practical points. Thank you, Dr. Raida. The next question is, how long can one perform hypothermic therapy in HIE baby? Maybe
anybody? I mean, I think it's if you do hypothermia, then normally it's done for 3 days, 72 hours. But I think the HELIX study really questions whether one should do therapeutic hypothermia in low to middle income countries. I think at the moment we don't really have enough evidence. I don't know. Joe, what do you think?
Yeah, I mean, it's heartbreaking because we know it's an important intervention, but if you do it, you need to do it properly. So, I mean, I think we still need to have the right tools, safe tools to do it. I was also going to say that if you do it as well, you need to do it early and not wait too long because you've missed the boat. And I think that's often a challenge that we have, that if the babies are home deliveries or there's been a long delay for people to realize or for them to reach the unit, you've missed an opportunity to intervene.
Mm-hmm. That's right. I mean, anything after 6 hours, there's no evidence that it helps at all.
Mm-hmm.
Yeah, I think you have touched the most important point, is that to start early and benefit of time, because as we have mentioned, every second counts. So the point is to start early, not the duration. So you will get the response better. Okay, next question is, how safe is IV lignocaine? If you have to use IV lignocaine, what is the dose?
So lidocaine is safe if it's done under in babies who don't have any cardiac abnormalities, and you have to have cardiac monitoring available for this baby. And you are able to really go according to the recommendations for the dosage. So they're very strict dosage. You change the dosage every 6 hours and you reduce it. So you first go up and then you reduce it over 48 hours. And it has to be extremely precise. Otherwise, the problem with lidocaine is that the therapeutic window is very, very narrow, and it can become toxic very quickly. So it is difficult to use, and actually in the UK people don't like it much, but in Sweden and the Netherlands they use it a lot. I think you have to be really comfortable with it. You have to know how to use it, and the baby needs to be on cardiac monitoring throughout.
Okay, thank you. We have a question, the treatment of epileptic spasm in neonate. We have got the answers. We can move on. Question, how long should you observe the seizure before starting phenobarbital? As we said, we have answered this question, every second count, and you have to consider treatment as soon as possible, as early as you can. And time really is critical in neonates. The next question, why generalized seizure are omitted from the classification? And pyridoxine deficiency seizure are usually generalized. Yeah, this is a good question, challenging one.
In fact, I mean, you're right. Some of the seizures in pyridoxine-dependent seizures look generalized, but if you look at the EEG, then it's still multifocal, and they also have focal seizures. So we assume that sometimes these seizures become bilateral very quickly. But even in pyridoxine-dependent seizures, you have focal seizures and you have focal onset seizures.
Yeah, the point here, as you have mentioned, is the onset. They would go into generalized seizure, but they have a focal onset of seizure, and this is the point. They have the focal seizures from the onset. That's it. They didn't omit, but they have most of them, or all of them have the focal onset of seizure. Okay, we can move on. Can you comment on the use of combination of phenobarbital and levetiracetam?
You know, in what context? I'm not sure in what way that's being asked. So, I mean, there are studies that look at crossover and use, and we certainly explored it as phenobarbital's first line and levetiracetam possibly a second, but we didn't have strong enough evidence to support it. Mm-hmm. But yeah, it is used in some units, and it'll probably be increasingly used if levetiracetam becomes cheaper and more available.
Mm-hmm. Okay. Next question, is there a role of hyperbaric oxygen therapy for infants diagnosed with early CB on background of hypoxic ischemic encephalopathy?
I would say no. Bonnet, do you want to answer that? But I would say no.
Yeah, I don't have also any experience with hyperbaric oxygen in neonates, and we don't have this practice in our government hospital. I'm just talking about our experience. I'm not sure about others. What do you think, Dr. Raida and Ronette?
Yeah, I agree. And it's not used.
Mm-hmm. Okay, we can move on. Yeah, okay, thanks for presentation. This is a compliment, very informative. And the next is how aggressive to treat electrographic seizures compared to electroclinical seizures. Yes.
Such an important question,
yes.
And one a very controversial question as well. I think there should be no difference between clinical and electrographic seizures, because we know that if we treat babies with phenobarbital, most seizures become electrographic if the baby doesn't respond. So this is uncoupling. So you have uncoupling with phenobarbital and phenytoin. If we make the seizures, if a baby has electroclinical seizures, we treat the spread of the seizure to the motor area, and this is the reason why they become electrographic only. Mm-hmm. And why should we change our management? Why should this influence what the seizures do, or what kind of response the baby has, and what an effect the seizures have on the brain development? So I would say treat them the same. There should be no difference.
Totally agree with you. Really, this is very important question, and the answer would be the same. Yes, I agree with you. Okay. Sometimes a newborn are found to have excessive incolossable cry. How to approach this in resource-poor setting? I would give them a trial. What do you think? If it is,
you know what I want to say, I think what we under address is pain, mm-hmm. and I would explore whether there's any reason for the neonate being in pain. Mm-hmm. And there's some beautiful studies with using, I think it's sucrose on the gums. I mean, Ronnie, you've probably got more experience with this than you guys have than I have, but I think sometimes we're so focused on the clinical boxes that we forget that the baby can actually express distress and can't explain why it's there. So there may be a number of reasons why there's inconsolable crying, and seizures might be one of them, and infection may be another. But actually, there may actually be genuine reasons for distress on the in the neonate case.
Mm-hmm. Okay, can we treat the suspicious clinical only seizures, since we know the limitation of EEG in uncovering the seizure always? So again, this question is, as we have addressed before, would you treat on a suspicion if you have limited sources to uncover the seizures like EEG or others?
I think it's important to use the Gaia flowchart that Joe showed. I think if you have focal clonic seizures and focal tonic seizures, then yes, you can treat, but anything else, most clinical only seizures, which are the so-called subtle seizures in the Volpe classification, are actually not seizures. They are mouthing, they are subtle movements. The vast majority of those are not seizures. So I think, yes, if you don't have EEG and you have focal tonic or focal clonic seizures, or sequential seizures with focal tonic and focal clonic parts, then yes, you can treat. But anything else with clinical only, I would be very suspicious.
Thank you. I think this is quite informative. Is it possible to make diagnosis of epilepsy in neonatal period? We have mentioned this. Yes. If it is continuous and it is a non-stop, recurrent attack and even unresponsive to treatment, and you have to go, go up with your anti-seizure medications, you can go to this level of diagnosing. Okay, we have some thanks and the appreciation for the lecture. As there is a question, any role of steroids for neonatal seizure? We have already addressed this question as well. And the answer, as you have move your head, is no. Okay. We have one more question. In our practice, we use diazepam, diluted 1:1, to abort seizure in our newborn and use phenobarbital for prophylaxis. We have not been recording adverse effects. Could this be due to inadequate active ingredients in the medication? I observed that benzodiazepine is said to used with care. So this is one of the inputs of their experience, their local experience. We cannot, you can, or you may give more inputs. Prof?
I think the problem with diazepam is the effect on respiration. So you can have apnea and increased salivation, all of which makes respiration more difficult, and you can run into problems with neonates.
Okay.
There's very little data-wise or study-wise on diazepam. The only thing I can add maybe is that in Toronto, they use lorazepam successfully, and quite a lot. They use it. They prefer it to everything else in neonates. But they haven't done any studies, unfortunately.
Yeah.
Okay. What if the baby's hypoxic ischemic score is not 0 on discharge? Should the phenobarbital still be stopped at discharge?
I think it's not whether the baby has neurological abnormalities, it's whether the seizures have stopped or not. It's the same thing. You have MRI abnormalities, EEG abnormalities, and then the baby had severe HIE, then of course there will be neurological abnormalities, and the Thompson score could be still abnormal.
Yeah,
that should not be the a reason why you stop or not stop. It should be whether you have seizures, whether the baby responded to treatment and has been seizure-free for a few days or not. Do you all agree?
Yes, I do.
Yeah.
I think, Ronnie, it's interesting because what Kunda's raising is where in settings where you can't always do all the tests, you use the clinical tools that you've got. So you do a clinical tool and it gives you the score and you think, well, what does it mean? And it's potentially a prognostic factor, but actually I think it's quite useful to then, and I think we need to think about this because it's a really valid point, to say, markers such as this still do not dictate your decision about what you're doing with the anti-seizure medication. You can still stop if you've got no evidence that there is actually epilepsy.
Yeah, actually, really facing neonatal seizures in practice is quite challenging time and quite hard time for neonatologists. We have a question, we have a question which is good to have an answer. Is there a place for ketogenic diet in neonatal seizures? In neonatal seizure, I wouldn't consider ketogenic diet. If it go into refractory step, maybe, but ketogenic diet in neonate, we don't practice this. In my humble experience. So what do you think?
It should be etiology driven, surely. In a setting where you know you're likely to have response, it would be related to the etiology, but certainly not routinely.
Mm-hmm. Unless it is GLUT1 deficiency, yes. Yeah.
Or PDH.
Yeah. Do you have any experience using lidocaine for managing the neonatal seizures, which cannot be controlled by phenobarbital and midazolam? Levetiracetam is not available in IV, or we can use the oral levetiracetam to manage as well.
That needs to be done as a study. I know of a couple of centres that have been using in fact, both the next two questions overlap that, using high dose oral levetiracetam or high dose oral phenobarb loading. So that's
oral. If you have oral, I think they can try for oral. It's no harm, but again, the response depends on the severity. But if you have limited sources, you have to use all your weapons, isn't it?
Yeah, exactly.
Yeah.
I think there are quite a few countries where you don't have IV.
Yeah, that's right.
And you can use oral with no problem, but obviously only in babies who tolerate oral feeds. If a baby doesn't tolerate oral feeds, you can't use it.
Yeah. Okay. Is there any difference regarding the efficacy when comparing IV versus oral phenobarbital?
Excellent question. Basically, we don't know because all the PK studies are done with IV. I'm not aware of any, I would need to look it up, but I'm not aware of any PK studies in neonates with oral phenobarb.
Yeah, only in older kids.
Mm-hmm.
Yeah. Okay, Dr. Raida, does a normal EEG rule out neonatal seizures?
Yeah, thank you for this important question also. As we know, there is in neonate, there is electroclinical dissociation. So you may see EEG changes without clinical. But if the EEG is normal, and the patient had clear clinical seizures, does it rule it out? Sometimes if the seizure is coming from deep structures of the brain, it may not show in the EEG, which is not very common, any findings. So normal EEG in neonate most likely will make you more comfortable to say the event of the baby is non-epileptic.
Yeah, and really the question, does normal EEG rule out neonatal seizures? I mean, seizures in general is a clinical diagnosis. So if you have seizures, clinically you have to treat, even if you have a normal EEG. Would you agree, Dr. Raida?
I think Dr. Ronit would like to comment.
Okay,
please.
I think we need to differentiate between an interictal EEG and an EEG of the episode. Yeah. So what we recommend in neonates is that you capture an episode. Mm-hmm. Otherwise, it's very difficult to exclude or diagnose seizures. An interictal EEG in a baby doesn't really exclude or diagnose anything. In a neonate, you need to capture the events and then see whether there's an EEG correlate or not. If you capture an event and there's no EEG correlate, we recommend to treat that, consider those as not being seizures. Because in neonates, the seizures usually have an EEG correlate. Maybe not the first one, but eventually. So in the ILAE classification, we do not consider clinical only events without an EEG correlate. Mm-hmm. If you capture the event. Mm-hmm. This is not, of course, true if you only have an intake EEG. That doesn't really help you to decide whether an event is a seizure or not.
Mm-hmm. Okay, excellent. Thank you. A question, what about cognition in neonates receiving phenobarbital at a later age? Rough.
It's a great question. We don't know. But we do know that if they're fitting and the fitting's not controlled, they'll probably get more complications from seizures.
Agree. Yes. Okay. Many thanks for the webinar. This is a compliment for from our audience. Thank you, Maha. What determines if the seizure would recur in neonates, or which group can we give maintenance phenobarbital, and for how long should it be for? Again, I think this question had been answered. Yeah. Okay. How long can we give phenobarbital before it becomes necessary to taper? Once you control, I think, seizures, exactly. you have to I think, consider tapering of phenobarbital. Okay. Next question, if we found etiology as structural abnormality in MRI brain, could we consider as epilepsy and discharge with anti-seizure medication?
So we don't diagnose epilepsy on the MRI, we identify etiology. So it's still a clinical call by the state of the baby and what the EEG is showing. So they may have structural changes, but it may not necessarily automatically reflect to them continuing with having seizures.
Okay.
It depends also on the MRI abnormality. For example, if it is hemimegalencephaly, for example, which is very abnormal MRI. So maybe, and the baby is seizing, so probably you would continue anti-seizure medication.
Okay, thank you, Dr. Raida. If premature baby presents with seizure and after intracranial ultrasound done, the result shows cerebral injury, should we continue with anti-seizure medication even after discharge? Again, the same, I think.
Same. Clinical.
Question. Yeah, it depends on a clinical. Do you think there is difference between phenytoin and fosphenytoin in efficacy in neonate? I think that is in practice, as it is mentioned, that fosphenytoin has less side effects. That is the question. But again, in neonate, you are using it for treating limited time. Okay. Again, next question, how much babies after hypothermia and medical treatment achieve at 6 years a nearly normal cognitive development? So this is need studies to get you an answer. Sorry. Okay. I have to go back.
Do you want me to read out the question from Diatoma, which is quite interesting?
Please.
It says, can an embryo, so I'm going to translate that into a fetus, have a seizure before birth? And the answer is yes. But there's often interesting etiological reasons for that. But it's a fascinating finding. So some of the metabolic conditions like non-ketotic hypoglycemia, that's where the mom reports hiccups. So it's really, really interesting.
True.
Question about whether you need to taper the phenobarbital when you decide to stop it. We don't. We usually just stop it because it kind of weans out the system. I don't know, Ronit, what do you do?
I think it depends a bit how long you have been treating and how many if the baby has been on anything else. So if the baby has been on 2 or 3 medications, I would not stop all medication from one day to another. Phenobarbital you usually can stop because the half-life is so long that if the baby has been on for a long time, maybe you taper it. Midazolam definitely has to be tapered.
Yeah.
So it really depends, I think. But yeah, I agree.
Really, we have a good interaction with our audience. I really appreciate their questions, all of them. Now we have a question, how aggressive to treat electrographic seizure compared to electroclinical?
I think we've addressed that, haven't we? Ron said the same.
Yeah. It would be the same. Yes, thank you. Excellent presentation. This is appreciation from our audience. Thank you. We appreciate also your appreciation. So, in a setting where IV levetiracetam is not available, how effective is oral route via NG tube? And after how long can you expect the drug to start working?
Well, I think obviously phenobarbital, if we give it IV, then we see a response within half an hour or even quicker, usually much quicker. So if you give it orally, you have to wait at least 8 hours before you know whether it has worked or not. Joe, what do you think, or anybody else?
No, I agree. I agree, and I don't know that the studies have been done. We don't know, but I know it's being used, and certainly some of the hospitals around where we work, they use it as well. We need to do the studies.
Yeah, absolutely. I think it would be really important to do a study.
Yeah, but I think in such centers that they have really this way to manage their patients, it would be worth trying, because even in these centers you need to support your patient or your neonates. So I wouldn't disagree, but it's worth to control the seizures, isn't it? Yeah.
And Phenobarbital is a cheap drug.
Yeah,
it's accessible and it's available everywhere. And as it was mentioned earlier, you want to act very quick on acute seizure in babies.
yeah, yeah.
Oral, it will be really challenging. If there is no other way to find the phenobarb, which is cheap, this is the, and here you will come to this dilemma starting oral.
Yeah. Okay. We have here Jessica, neonatologist in Uganda. Her question is, how in low resource setting, like in her situation, we have pulse oximetry to monitor the neonate. How accurate can DSATs or abnormal heart rate be used as a proxy for electrographic seizure occurrence in the absence of EEG? Good question. Who would like to answer?
Very good question. Unfortunately, we don't really have an answer. If I look at my EEGs, which we do here, then in the vast majority, we get lots of requests to an EEG because the baby has heart rate changes, bradycardias, apneas, anything like that, or blood pressure changes. And in the vast majority, these are not seizures. 98% are not seizures. It's very, very rare that you have, as an only manifestation of a seizure, changes in blood pressure or heart rate. I would be very careful with that. I think the risk is to overtreat. And if you give a baby in such a setting, phenobarbital, you might make them change their respiration. We know that phenobarbital sometimes makes baby ventilator dependent. It's a great risk, I think.
Okay, so thank you, and hopefully you will find, really, we support your situation, but hopefully you will get the best practice in your setting. Okay, When administering phenobarbital, should we always start with a loading dose in regard to neonatal seizures? Of course, I think. What do you think?
No, we agree. We agree with you.
Yeah. We have more appreciation from our audience. We thank you also for keeping up with us, and you are really a very interactive audience. I love your questions. We have one of the most from Mohammed Al Malik, one of the most common consultation for neurologists to review apneic baby and to decide whether it is seizure or not. What the panel approach to that consultation?
Yeah.
What do you think? Yeah.
We always get
babies,
consultation, neonatal apnea, and rule out seizure. We know it can be a seizure, but we need to exclude other etiology for apnea. Is it respiratory, which is the most common? Is it GERD? We see it in gastroesophageal reflux. So other etiologies is more common than any seizures itself. And if all of the other etiologies was excluded and the patient had repetitive apnea, it will be very easy to do video EEG monitor and capture one of these events to see if this is epileptic or non-epileptic.
Thank you, Dr. Raida. Here we have, when do you start vitamins in neonatal seizures, in neonatal status? I think we got an answer earlier that when it gets really uncontrolled, you have to give a trial of vitamin support. Okay. Thanks for the good talk and discussion, very informative. We thank you also for we have many compliments. We really appreciate your stay with us and your interaction. That was really very healthy, very productive review. They have one question: rectal phenobarb in neonate with difficult IV access. What do you think?
I'd rather give it orally.
Okay. Okay. If the EEG is normal with the clinical events for a neonate, would you still advise for LTM?
No.
Long-term monitoring.
Oh, long-term monitoring. Is that what LTM is?
Yeah.
You should be doing long-term monitoring if you can, regardless.
Okay. Okay. We have many questions coming in, and we can go ahead now. Can midazolam cause neurodevelopmental impairment at 2 years? Again, we need studies to confirm this. Okay. Many thanks. We also thank you for your stay with us. Wonderful presentation. Thank you. This is a compliment for you, Prof. Wimhurst. In our country, IV phenobarb is not available. This is as well as IV phenytoin. What would you recommend to use as a first line of treatment? Levetiracetam IV? This question, I don't know which country. Olga?
That's but I mean, I'm just slightly speechless about why the other two agents are not available. I mean, we have to get IV phenobarbital imported. We do a Section 21 bulk import, but it's vital for us. But I mean, I would question why that's not there, because certainly it would be the more cost-effective intervention, or even IV phenytoin. Ideally, if you're questioning getting IV levetiracetam, then sure, that sounds like you should be able to get any of the agents.
Okay. We have a question here. I think we are going to wrap up now. How many times should a baby receive a loading dose of phenobarbital in 24 hours if it still continue to have seizures?
Actually, we follow a level of Phenobarb, and
Yeah.
you can give 20 per kilo. It can be repeated, and the level, the ideal is 60. Sometimes we go higher. Of course, the baby will be intubated a little bit higher, so it can cause, and you will be afraid about cardiopulmonary suppression. So this is the first line. If it fails, you should go to the second line, as it was mentioned earlier.
Mm-hmm.
But we usually follow level to see where we at.
Okay. Here we got a reply from Olga. She said it is not registered in Russia.
That's amazing. I didn't know that. That's
for me also. I don't know that.
Yeah.
So
thanks, Olga, for telling us. We need to help you with some advocacy there.
Yeah. We have the last question. Should a baby with a neonatal seizure be avoided of whole cell pertussis vaccine? Regarding vaccination.
That's a fantastic question to end on. There is absolutely no contraindication. Vaccinate the baby.
Yeah.
Vaccinate the baby. Okay. Thank you, Mohammed Shah, for the question. I think we are wrapping up. This is the last. And we thank you, our panelist, our distinguished speaker, and your really inputs were productive. And we have to thank our audience. Really, they are very, very interactive with us. And it was a lovely night with you. Thank you so much. Thank you all. And I have enjoyed really this evening with you. And we'd like to wrap up now and close up our session or our meeting. If you have any further comments, so you can add. The floor is yours.
Thank you very much. Thank you so much for such superb chairing as well. It's been really fun, and as you said, the group have asked such fantastic questions. It's really, really excellent.
Yeah,
Thank you.
I agree.
Thank you very much. It was a fantastic discussion. Thank you so much.
Thank you.
Yeah, Ronette, you were really helping us a lot in your experience, as well as beautiful, as well as Raida. Raida, if you have any comments before we wrap up.
Yeah, thank you so much. It was really great, wonderful discussion and a lot of interaction. So really, thank you.
Yeah, I enjoyed it. Thank you so much.
Thank you. Bye-bye, everybody.
And see you. Have a lovely evening. Bye-bye. Bye-bye. Thank you.